Thanks, Paul, for the introduction and for the honor to present here on behalf of Minneapolis Heart Institute on this topic. And I would just echo what Maurice said, that if we consider that mitral valve has not been, these patients have not been referred to surgery, when you add mitral calcification, then that's another reason for deferral and for lack of treatment, even on the transcatheter therapy world. Those are my updated disclosures. There are a couple great reviews more recently published on the topic of mitral calcification. One of them is by Abramovitz and Rajmakar from the Cedars-Sinai, highlighting the importance of this topic. We can see this by echocardiography, but by CT we provide a much more granular detail. The prevalence varies across several studies. Certainly seems to start at the posterior annulus, right around P2, and then moves into the commissures, then trigones, and then finally the last one to be spared would be A2. The morphology seems to be better captured, better understood with CT than echo. There are some important risk factors and that we see this association frequently, obviously, as we age. Female gender, chronic kidney disease, a huge burden of not only coronary disease, valvular disease, and obviously several other things that can be associated with that, predominantly the group of aortic stenosis. This is a group that we see frequently, that we have been treating them with TAVR, and we try to see, does mitral regurgitation improve after we fix the aortic valve? But some of these patients still limping around with significant mitral stenosis or mitral regurgitation. The implications of presence of MAC obviously has to do with the burden of valvular heart disease, arrhythmias, and even associated with a higher risk for surgical interventions. This is a nice paper that came out actually from the group from Scotland in Edinburgh. It was trying to understand what drives MAC and how does MAC progress. They are a very prominent group that has been studying calcification of the aortic valve, and they have been looking at the PET-CT scan using a marker here, the sodium fluoride, which is a marker for calcification activity, and they were trying to track on the aortic valve. Obviously, the mitral valve was being exposed, and what they saw is that the 60 patients that had a CT, PET-CT, a follow-up at 2 years, is that there was a progression in some of these patients. And what drove the progression of mitral calcification was obviously the amount of calcium that they had to begin with, as well as the uptake of the sodium fluoride. So this might be a marker that more calcification, injury, inflammation might be driving, perpetuating this process. Obviously, the role that TMVR plays into us nowadays and has proposed is, can we fix and can we try to use that as a potential anchoring system? The TMVR, although for some annuloplasty device therapies, they have to exclude patients with mitral calcification. For other therapies, particularly for the valve and MAC, it serves as an anchoring mechanism. The other great definition here that has been proposed by Mac Elliott, who is here with us in this conference, has been into this grading system and considering for particularly grade 3 when the arc of calcification achieves 270 degrees. Definitely involving not only the posterior but anterior leaflet and sometimes even going into the myocardial wall. And this is the patients that they present on the paper, with these patients that have this extensive calcification, and all the way around also involving the aortic valve in these patients with grade 3. Obviously, it did not describe the common scenario that sometimes we face with patients with cases MAC. This is like the cheese curds, there's a milky, there's a potential for embolization, a potential even for perforation of this ventricle. When it's circumferential but not contiguous, you have a lot of MAC, but they are islands, they're not uniform. What does it happen to it? What does it happen when you have protruding calcification to ventricular wall and this invasive MAC? How do we do that with CT? And I'm glad to hear from Steve that he's been using more and more CT to provide this granular detail. We're trying to segment this obviously with a curved spline. There are softwares that provide that. We should try to tackle at the edge approximately 10% into the mitral annulus and trying to make this annular dimensions, which will be important obviously for the size and the potential device that we're going to be using. And predicting obviously the risk of LVOT obstruction that has been shown by Didi Wang, by Yoon and many others to be around 1.7 to 1.9 to 2.0. This keeps changing as we try to refine more and more. Now, the series of Mayer-Guerrero was an important one in the context of TMVR for MAC to show that this is a significant high-risk group. If you look at just the 30-day mortality, you had 31% mortality. So so 1 in 3 patients. It obviously improves with the refinement of the techniques for the sizing and for the procedural planning to 19%, but that's still 1 in 5 patients would not make it to 30 days due to procedural complications and high burden. This is just one patient from our group showing that we had a SAPIEN 3 in MAC with adequate response. This is another classification too that has been proposed by Gilbert Tang. This was an abstract that was presented at the ACC, a publication forthcoming, that looking at patients that were evaluated for potential TMVR with MAC. He integrated the MAC extent in this clock phase. He looked at the LVOT obstruction and the annular eccentricity, how much of the AP divided by the AI, the intracommissure diameter, and he saw that about 65% of the small cohort of only 30 patients that they presented in the form of the abstract were completely not eligible for TMVR due to the high risk of obstruction and other problems. So therefore, still we don't have a good solution by using the inverted SAPIEN valve into the mitral calcification. CT also is now allowing us to do a granular quantification of this mitral annulus. This is a new software that Circle has been providing that provides us the amount of calcium, what we call the volume of calcification, which might be another marker that we need to utilize in terms of adjusting for that. But it's not as simple as that. As we're trying to simulate, and just in this short video that I demonstrated, we don't have a three-dimensional understanding of the depth of the MAC if we just look from one single plane. So that is why it is important, because the anchoring might not be occurring just here at the surface, but rather deep down, and we don't have ways to simulate and not simulate also the length of the anterior leaflet. This is a case that Paul has really pioneered this field in trying to use a new device. As you saw this patient some slides before, we did the segmentation of the CT, whether you do it at systole or diastole. The area was way too large for any SAPIEN device. Even despite simulating here 23, we got this new LVOT of about 3. And therefore, the Tendyne was implanted. And Tendyne, as you know, is a device that has an apical pad, facilitate the anchoring, as well as the fixation here into the mitral annulus. By using a mimics, a materialize, they got a new LVOT by the Core Lab about 3.1, so similar to us. And with the STL files overlaying into the mitral calcification, we can see that this very extensive degree of MAC invading into the ventricle as well, and into the trigones that were mobilized prior to that with balloon valvuloplasty to kind of prepare the landing zone for this device. These are the images of the first device implant with very good success, and the CT showing the follow-up for this patient without LVOT obstruction. This was the first case, and recently the results presented for the first 8 patients treated worldwide. And you can see, if you recall, that first years from Myra Guerrero showing that 30% DAF at 30 days. We had no 30-day DAF and no residual MR, with a lot of patients still deriving benefit from this, and the results are upcoming in JACC. So therefore, the definition of MAC continues to evolve. While for some annuloplasty device, MAC should be and is a contraindication for TMVR, particularly with certain devices, it serves as an anchoring mechanism. CT will continue to provide this granular anatomical detail. The technologies will continue to evolve into this organic natural selection that will identify who are the potential viable techniques and strategies. And this permissibility to adjunctive therapies will be important in consideration this moving forward. And I'd like to thank again for the opportunity for my wonderful team at Minneapolis Heart Institute. Thank you.